of talk, so I'll go ahead and get started. Morning. My name's Tim, one of the fellows. We'll be talking about adult spinal deformity. And so, the outline of our talk today, we're going to go over what makes a good classification, some of the important measurements in adult spine deformity, the historical classification, as well as the current classifications. First, a accurate classification characterizes the nature of a problem and then guides treatment decision making, ultimately improving outcomes. Secondly, accurate classifications establishes an expected outcome for the natural history of the condition or injury, informing a basis of uniform reporting of results for various surgical and non-surgical treatments. This allows the comparison of results from different centers treating the same entity. A successful classification system must be both valid and reliable. And reliability reflects the precision of a classification system. In general, it refers to inter-observable reliability, the agreement between different observers, as well as intra-observer reliability. It's the agreement of one's observers' repeated classification of a entity. The validity of a classification system reflects the accuracy with which the classification system describes the true pathologic process. A valid classification system correctly categorizes the attribute of interest and accurately describes the actual process that's occurring. To measure or quantify validity, the classification of interest must be compared to some gold standard. In 1960, Cohen introduced the CAP value as a measurement to assess agreement that occurred above and beyond the that related to chance alone. And so today, the kappa value and its variants are the most accepted method of measuring the observer agreement for categorical data. And as you can see from the graph there, anything above 0.6 is substantial, and then above 0.8 is almost perfect. So higher the value, the better the intra-observer reliability. The Cobb angle shown here is the angle defined by the intersection of the two lines, one perpendicular to the cephalad end plate of the most angled vertebra above the deformity, and one perpendicular to the caudal end plate below the deformity. An angle greater than 10 is considered scoliosis. The pelvic incidence is the angle between the line drawn perpendicular to the sacral end plate at its midpoint and the line drawn from that midpoint to the midpoint of the bicoxfemoral axis. This angle does not change during motion. The lumbar lordosis is the Cobb angle measured between L1 and the superior end plate of S1. Pelvic tilt is the angle between the midpoint of the sacral end plate to the midpoint of the bicoxofemoral axis as the vertical, and this angle changes with positioning of the pelvis. Finally, the SVA, or the sagittal vertical axis, is defined as the offset between the sagittal C7 plumb line and the posterior superior corner of the sacrum. Schultes in 1905 originally classified scoliosis into 5 ordinal groups: cervical thoracic, thoracolumbar, lumbar, and combined double primary. This largely remained unchanged until Ponseti in 1950 retrospectively described 394 cases of idiopathic scoliosis that were treated conservatively. Unfortunately, most classification systems primarily dealt with pediatric scoliosis at this time, as the technique and technology to treat adult deformity didn't mature until recently. Ponseti described 5 curve patterns, which corresponded closely to what Schultes had previously described. He went on to describe which were most likely to progress, most common at onset, and other descriptive characteristics. In 1973, Goldstein published a etiologic classification where they expanded on the curve patterns. Idiopathic did not have an identifiable underlying cause and was further divided by age. Infantile was under 4, juvenile 4 to 9, and adolescent between 10 and skeletal maturity. Congenital was broken down into abnormal bone development, such as failure of segmentation or formation, resulting in various deformities. Abnormal spinal cord development, such as myelodysplasia, and congenital due to mixed causes, such as myelomeningocele. Neuromuscular had composed of either neuropathic or myopathic scoliosis. Neurofibromatosis had its own category, and finally, mesenchymal disorders, both congenital, such as Marfan's and arthrogryposis, and some acquired, such as rheumatoid arthritis. The final classification category was due to trauma, which included fracture, but also included scoliosis due to surgery, idiopathic, and radiation. While classification was descriptive and helpful for the natural history of the disorder, it didn't really provide much. It didn't provide accurate classification or allow for description of the deformity, such as way to compare different cases or even guide treatment. In 1983, King described their institution's methods for selective fusion and how they determined which levels to fuse. It was a retrospective review of patients who underwent surgical treatment for idiopathic thoracic or combined thoracic and lumbar scoliosis in Fairview Hospital. And it was done over a 30-year period. They defined scoliosis curves as shown up on the screen. Additionally, they defined the stable vertebra that was most closely bisected by the line defined as a perpendicular to the iliac crest and centered over the center of the sacrum. They noted that type 2 curves that were selectively fused down to the stable vertebra appeared to have spontaneous correction of the lumbar vertebra. However, once again, this was primarily for adolescent idiopathic scoliosis and not adult deformity. And so it didn't account for degenerative conditions. And at that time, few surgeons were correcting adult deformity. And in 2001, Dr. Linke published a new way to define AIS, which continues to be widely used. I'll go over this briefly as Nikita went into great depth in his talk. It consists of 6 curve types and has lumbar and thoracic sagittal modifiers. It defines major curves as a large measurement, and they are always considered structural. Minor curves are assessed with side bending films, and so Dr. Mundus also has a very quick and easy way to memorize all this. This is a prospective self-analysis and evaluation of nutrition and radiographic parameters in a consecutive series of healthy adult volunteers that were older than 60. There were 75 subjects in the study with no history of prior spine surgery and no known history of scoliosis. The goal was to assess the prevalence of radiographic scoliosis and assess for any correlation with SF36 scores and nutritional status. No significant correlations were found, however. The prevalence of scoliosis as defined by greater than 10 degrees, as shown in the pie chart of groups 2 and 3, was 68%. And so it was a lot higher than the previously reported 1.4 to 32% prevalence within our population. And so this emphasizes the necessity to really define a classification system for adult deformity, one that meets the requirements for useful, accurate classification. And this is important as the demographics of the US and the world shift and the general population ages. In 2005, Max Aby proposed a etiologic classification for adult deformity. Within this classification, he attempted to identify which type of curves would progress and what treatment, if any, was appropriate. He divided his classification up into 3 primary types, with a third type subdivided into 2. So type 1 was primary degenerative scoliosis, or de novo. This was mostly located in the thoracolumbar or lumbar spine and mostly developed on the grounds of limited disc degeneration in one or more segments, and so it could also be termed discogenic curves. And the apex was usually between L3, L4 or L2, L3, and it developed only in adult life and resulted in some sort of flat back or lumbar kyphosis. He attributed the patient's pain to the sagittal malalignment. Type 2 curves were defined as progressive idiopathic scoliosis that had been present since adolescent or childhood. And again, the sagittal deformity was almost exclusively a flat back syndrome with loss of physiologic lordosis and in some cases kyphosis. So type 3A, considered degenerative scoliosis, was usually located in the thoracolumbar or lumbar segments, either from within the spine or outside of the spine was the cause. And it may be a result of idiopathic congenital or neuromuscular conditions, or a result of a lumbosacral anomaly. Type 3B was used, so type 3Bs were due to bone weakness, like metabolic bone disease, osteoporosis, fragility fractures that caused deformity. So this classification did not address the varying severities of deformity, and it didn't significantly guide treatment. However, within the classification, we see the beginnings of attention to sagittal balance, which the author mentions often when describing these various types of scoliosis. Lowe, along with the SRS, proposed this classification system for adult deformity in 2006. Prior to this classification system, there were primarily focused on pediatric scoliosis, not taking into account important considerations that are inherent to adult spine deformity. The recognition of symptomatic degenerative changes within deformity, including stenosis, spondylolisthesis, rotational subluxation, were considered critical for an effective classification system in the adult. Additionally, global imbalance of the spine in the sagittal and coronal plane is rare in AIS, but has an important impact on the health status and treatment options for adult patients. The role of non-operative care, decompression alone, limited stabilization, or long fusions have not been well defined and remain poorly defined in absence of a valid classification system that can be used to categorize and report outcomes on specific presentations of adult spine deformity. An evidence-based approach to the management of adult spine deformity requires a valid classification as the starting point. And so this classification system defines 6 major curves: single thoracic, double thoracic, double major, triple major, thoracolumbar, and lumbar. And once again, the curves have an apex between T2 and the T11, T12 disc, thoracolumbar between T12 and L1, and lumbar between L2 disc and L4. Primary thoracic required a curve above 40 degrees and the C7 plumb line to lie lateral to the apical vertical body of the curve. 40 degrees was chosen in order to identify curves of significant magnitude to warrant consideration of extension of instrumentation and fusion. Upper thoracic curves are structural if the first thoracic rib or clavicular tilt is greater than 5 degrees, with the elevated side ipsilateral to the apex of the deformity. Thoracolumbar and lumbar curves included a curve magnitude of 30 degrees and a center sacral vertical line that passes lateral to the apical vertebral body of the curve. Sagittal only deformity consists of no major coronal curve and any sagittal modifier that is out of normal range, which is listed here. The lumbar degenerative modifier was not added to quantify the lumbar degeneration that is often present. Was added to quantify the lumbar degeneration that's most present in adult deformity, but not juvenile. And finally, the global balance modifier was used to identify any coronal or sagittal balance. Although this gets like super descriptive, this is like even describing it here was like a handful, and like trying to convey this or use this between surgeons to guide management and treatment or talk about cases, it would be very difficult, but it was a start point. And so with regards to the reliability, 14 surgeons completed evaluations for 25 cases. Interobservable reliability kappa curve was 0.64. For the sagittal modifier, it was 0.7, lumbar degeneration 0.65, and global imbalance was 0.92, all of which are substantial to excellent range. So around the same time, Bruce Lee published his classification of the adult sagittal alignment. In his words, normal coronal curve is well defined or straight. However, the natural curve of the spine and the sagittal plane makes it hard to define what is normal. And the significant variance within a asymptomatic population only serves to make defining normal more difficult. He took 160 volunteers with no history of scoliosis or chronic back pain and obtained full-length standing AP and lateral radiographs. He then attempted to classify the sagittal curve into four types. To do this, he identified some important radiographic parameters that he help delineate the curves. To start, he used sacral slope and based the types on less than 35 degrees for types 1 and 2, 35 to 45 degrees for type 3, and greater than 45 degrees for type 4. And to differentiate between 1 and 2, he looked at the lordosis tilt angle apex. If it fell within L5, it was type 1. If L4 was type 2. This was a cross-sectional study identifying normal anatomy. However, they did not say asymptomatic patients were type 3, while patients with symptomatic disc herniations were often type 1 or 2, and those with claudication were usually type 4. And so, as the interest in sagittal alignment increased, Lafarge published this prospective clinical trial in the Spine Journal in 2009. They looked at 125 adults suffering from spinal deformity with a mean age of 57, full-length freestanding radiographs, including the spine and pelvis, were obtained. Patients filled out health-related quality measures. There was no correlation identified pertaining to coronal parameters. However, the sagittal vertical axis and the truncal inclination correlated with the ODI, SF12, and the SRS measures. Pelvic tilt also showed a correlation with both quality of life measurements and sagittal vertical axis. They determined that high values of pelvic tilt expressed compensatory pelvic retroversion for sagittal spinal alignment. As you can see in the charts, as the pelvic tilt increased, the ODI increased, and SF12 physical component score decreased. The chart on the right shows how the groups were broken down. The authors also looked at combining pelvic tilt with SVA. They created four categories in which a ANOVA analysis revealed significant differences with quality life scores. Pain and disability increased as patients moved from category 1 to 4. This is important because it identified important radiographic parameters that correlate with disability and quality of life. Good classification should take this into account, and additionally, if surgeons can restore some of these radiographic parameters, it might help guide treatment for these patients. In 2012, Schwab published a validation study of an updated classification system with that both simplified the scheme as well as included pelvic parameters. It was initiated by the SRS Adult Deformity Committee to revise a previously published classification system. 9 readers graded 21 pre-marked cases twice, 1 week apart. The kappa values were also calculated. The intra-observer kappa for curve type was 0.8 and 0.87 for the 2 readings. The modifier kappa value was 0.75 and above 0.97 for pelvic incidence minus lumbar lordosis, pelvic tilt, and the SVA. And so very high kappa values for measuring these radiographic parameters. The coronal curves were simplified to thoracic, thoracolumbar, or lumbar only with and double with 30 degrees used as a cutoff. Thoracic curves greater than 30 with lumbar curves less than 30 was defined as thoracic only. Similarly, thoracolumbar or lumbar only had a curve greater than 30 with the thoracic curve less than 30. A double curve had to have both thoracolumbar and thoracic curves greater than 30 degrees. These sagittal modifiers were added in. Pelvic incidence minus lumbar lordosis with the parameters here, global alignment was carried forward, but only using the sagittal alignment. And pelvic tilt was either less than 20, 30, or greater than 30. And so, for example, the curve on the right has a thoracic cob angle of 72 degrees, apex T9, lumbar 59 degrees with apex at L2, L3, pelvic incidence 59, lumbar lordosis 44, PILL mismatch of 11, pelvic tilt 24, and SVA of 16. So it would be described as a double curve with PILL plus and PT plus. The authors found an excellent reliability for curve type and modifier with the entire classification coefficient greater than 0.81. It incorporates sagittal alignment and pelvic alignment, which recent studies have underlined the importance of spinal pelvic alignment along with pain and disability. And as more adult deformity is treated, the classification system becomes important to facilitate an evidence-based approach to evaluate and if for evaluation and treatment of adult deformity. This classification system will likely continue to evolve. Um, and so recently continued to publish multiple articles on sagittal plane alignment. Most recently, and his team readdressed his classification. Specifically, they wanted to address asymptomatic patients with an inverted pelvis and include it within their classification. This was a prospective radiographic study of 296 asymptomatic patients. They assessed the pelvic incidence, sacral slope, pelvic tilt, and lumbar lordosis, tilt angle, and the total number of lordotic vertebrae, the C7 plumb line sacroperoneal distance ratio. They identified a fifth type, which they termed type 3 AP. It was a type 3 curve with a low grade pelvic incidence. Once again, they used the same sacral slope cutoffs for each of the groups. And here is an algorithm method to determine the type of curve. The image on the right, it's taken from their article. They note that that preoperatively the patient had an inverted pelvis with a near zero pelvic tilt who complained of severe low back pain and high disability when attempting to stand upright. The fusion led to decreased lumbar lordosis, which induced a pelvic retroversion and increased the pelvic tilt. Of note, this moved the C7 plumb line from anterior to almost neutral and appears to have restored their sagittal balance. They noted that the C7 plumb line changed with spinal pelvic type. The type 1 was the most posterior, type 3 and 4 and was a more anterior position and sometimes in front of the femoral heads. Authors noted that once again, there was a high correlation between global lumbar lordosis and sacral slope. They also noted that females in general had a lower pelvic tilt, which they felt represented an important characteristic in female adult deformity correction, suggesting that restoration of lumbar lordosis may be more necessary in women. Finally, they did state their study population was small and composed mostly of young adults. It was also comprised of only Caucasian subjects, so the generalizability of this information may be limited. In 2022, Dr. Kelly Hill Lenke, along with others, continued the idea of identifying sagittal plane alignment imbalance in asymptomatic adults. Alignment targets prior to the study looked at correlation between radiographic and quality of life measures in spinal deformity patients. Their goal was, however, to create these alignment targets by studying disease-free patients. They looked at 320 volunteers and found that the CT tilt was independent of pelvic incidence with minimal variation, and pelvic incidence was inadequate for estimating a normal lumbar lordosis. However, they found that the pelvic incidence was strongly associated with lumbar pelvic angles, L1PA, so the L1 pelvic angle, and therefore L1 L1 lordosis defined as a function of the pelvic incidence and the L1PA. The T4PA is nearly equivalent to the L1PA, leading to the aligned T4L1 hip axis. And so the equation, the L1PA PI times 0.5 minus 21, and then the T4 L1PA mismatch equaling 0 came from this study. And the ISSG group went on to examine the clinical implications of realignment to a normal L1PA and a T4PA L1PA mismatch through a prospective multicenter adult spine deformity registry. They looked at patients who underwent T1 to T5 region to sacrum pelvic posterior spinal fusion with instrumentation, 2-year radiographic follow-up. There was 247 patients with mean age of 64 and 82% were female. Deviation from a normal L1PA or T4 L1PA mismatch in either direction was associated with a significantly higher risk of mechanical failure, independent of age. The risk was minimized with the equation shown to the right. The L1PA PI, or L1PA equal to PI times 0.5, subtracted by pretty much 20. And then the T4 L1PA mismatch between 3 degrees and minus 3 degrees and plus 1 degree. So like plus minus 4. So with these findings, they concluded that obtaining these modifiable alignment targets of L1PA and T4L1PA mismatch in patients undergoing long fusion to sacrum may lead to fewer mechanical failures. So this is another study by the ISSG that's in process of publication. It looked at 627 patients and included in the study with primary outcomes of proximal junctional kyphosis. PJK developed in about 39% of patients with lower thoracic instrumentation and 12% in patients with upper thoracic upper instrumented vertebrae. A significant interaction between the preoperative C2T9 pelvic angle and UIV region was observed with a p-value of 0.03. Indicating that the risk of PJK associated with a preoperative C2T9PA depended on the upper instrumented vertebra. With a preoperative C2T9PA of 14, a upper thoracic GIV had an adjusted ARR of 39%, and the number needed for benefit was 2.6 patients, and so it's very high numbers, and benefit numbers pretty low. Females had an adjusted odds ratio of 1.6 for developing PJK. This demonstrated that this is demonstrated with that graph on the right. That's like a really good visual of putting this into a kind of context, I guess, between the upper and lower thoracic UIVs. As the C2T9P increases, the probability of the PJK increases, as shown in the dashed arrows shows the respective adjusted absolute risk reduction and the number needed to expose benefit for one patient. So we discussed a lot of sagittal balance and over the last few slides and the importance of it. However, in 2016, Bao attempted to address coronal deformity and its importance to spinal balance and deformity correction. He defined three types. Type A, which is considered to be balanced when the coronal balance distance or their horizontal distance between the C7 plumb line and the center vertical sacral line is less than 3 centimeters. Type B is when that line is greater than 3 centimeters and is displaced to the concavity of the lumbar deformity, and type C when it's greater than 3 centimeters and displaced the convexity of the deformity. This was a two-stage prospective and retrospective study with 284 patients prospectively recruited in stage 1, 99 of which presented the coronal imbalance of type B or C, and stage 2, 99 patients who underwent a posterior only correction of degenerative lumbar scoliosis were identified. For the stage 2 patients, the quality of life measures included SF-36, ODI, VAS scores. They were all obtained and assessed. They found that type C were more likely to have continued coronal imbalance post-correction, as seen here on the second table on the top right. They also found that patients with post-operative balance were more likely to have higher quality of life scores of VAS and SF-36, underlying the importance of also correcting the coronal balance. They noted that when correcting the type C imbalance and an asymmetric osteotomy to correct the type C deformity at the apex may actually worsen the coronal imbalance, and so they recommended leveling procedure below L4, restoring the horizontal level of the L4 and L5 for proceeding and correcting the concave side of the main curve. And so Bao only addressed the lumbar scoliosis, degenerative lumbar scoliosis, and Obeid attempted to classify and address the deformity up to and including the thoracic spine from a coronal alignment standpoint. He identified two main types, similar to Bao, in which the type was defined by the coronal malalignment was either to the convex or the concave side of the deformity. Type 0 was no malalignment, type 1 was concave, and type 2 convex. He then assessed the flexibility of the curves with side bending radiographs, some of which were done over a bolster or post, as well as the location of the curve. The algorithm here shows it demonstrates how the curve was identified on the table, and the table on the right loosely details the recommendations for location of the correction. Once again, the identified convex malalignment was as requiring special attention as correction of the main curve in isolation would worsen the malalignment. And so, in conclusion, classifications are important. They allow us surgeons to identify, quantify, and categorize pathologic conditions, and good classifications systems are easy to apply, memorable, and both guide treatment as well help identify prognosis. Adult spinal deformity is complex issue and varied presentation. The most recent classifications for both sagittal and coronal deformity help guide treatment, and only recently surgeons have had the tools to help correct this deformity reliability. I know that was a ton, but thanks for listening. And these are the references.
So what classification should you use? They're so important.
The ones that we've been using for our presentations. Like try to figure out what their normal used to be, and then like the radiographic sagittal alignment parameters as our goals, and that helps guide our treatment and kind of tells us what the prognosis will be if we meet those goals. with the most recent sagittal alignment papers that we presented on. And so, like, how we make the pre-op plans for our deformity patients is a very reliable, I think, a good way to help these patients.
So are you using a classification?
Not really.
Okay, so
But I mean, except the Rusely.
yes, we use R types, but is that perfect? Like when we're in clinic, we're looking at patients.
And then
How much agreement do we have amongst ourselves as we're saying what R type is that?
It's difficult.
And you're trying to predict what they were 30 years ago.
Yeah. And so I had this thought of like patients once they reach skeletal maturity as like a pediatric, like end of pediatric care, like globally, like just get it EOS.
Baseline EOS for life.
For every single patient. And then like since the prevalence is so high of degenerative adult scoliosis, you can refer back to that.
Maybe if there's like risk factors or family history or something.
I mean, I feel like that's definitely part of it, but I don't know if it's been hit on or talked about.
Is that movie called Gone Baby Gone? No, what's it called? The Clint Eastwood boxing movie with the guy, $1 Million Baby. $1 Million Baby. Can't put baby in a box. Remember that? I feel like whenever we do like classifications, we're trying to put things in boxes. And then there's the outliers. We have to shove them somewhere.
Yeah.
You shove those outliers somewhere, which skews the data. The reason why the SRS-Schwab classification had such high values is because when we did the surveys, they would hand you the slides with the numbers on it. And all you had to do is like, if you could read, you should be able to classify it because they would tell you what it was. And then you would like, literally say, they would tell you PI minus LO was 12. And then you're like, okay, that's a modifier. So that's why it's like 0.97 is because, and so that's not really, adult deformity is such a complex thing that I think it's very difficult, and I think some of us would argue should not be classified, right? At the extreme, as you're learning, I think for residents and fellows and early in career probably is helpful because you have to figure out how to organize all this information. So having boxes is helpful from an organization standpoint. Ultimately, I think as you get to know it better, you should take the boxes away and start looking at everything as a continuum, which is really what I think it's about. Yeah. So over Christmas, so last year and a half, there's been a Delphi study on trying to define adult spinal deformity with the ESSG and the ISSG. So it's like 36 surgeons like that, or, the guys leading all the societies and all that stuff. So we're sitting there and there must have been like 90 emails per Delphi round about like arguing this point or that point and this and going back and forth and going back and forth. And it was about a year and a half at Christmas. And the guy and Javier Pizona sends out an email. We're done. We're not publishing it. We're not, because we could not find agreement on how to define adult deformity. So we can't define it. How are we supposed to classify it? You know what I mean? It's like, so I think it's pretty intense. And everyone's like, we need to go to AI algorithms. We need to go to clusterings. We need to do like, at the end of the day, it's like, we look at these patients, try to understand their disability and then figure out if they need something big or something. Can we have something small, like, so.
I know it when I see it.
Yeah. Yeah, that's exactly right. Yeah.
I think it's also important to makes you realize that you have to stay on top of the literature for this stuff, because if you're like 15 years in practice and you're not reading the new papers, like you're still doing, PI minus LL, and like you're messing people up, right?
Yeah.
And it's going to change from now in 15 years. It'll be totally different.
Yeah.
5.
Yeah.
That's great.
Yeah.
Jeez.
Yeah.